Well, good afternoon, everybody. My name is Jason Belden. I'm the Director of Emergency Preparedness for the California Association of Health Facilities. Today is June 5th, 2020, and you've joined us for our COVID Weekly Roundup. This week, we're going to be covering a bunch of different topics. OSHA, testing labs, reporting, resuming visitation, and then what's coming up this week. We won't cover them necessarily in that order, but we'll cover all those topics on the call today, and then we'll leave some time afterwards for questions as well. And then there's the website if you want to take a look at any of the resources that we've gathered. We try to collect most of the or all of the most recent AFLs, put them in a timeline, and list them out: CDC guidance, CMS guidance, guidance from our national association, as well as tools and templates that we've developed specifically for coronavirus. So, all right, well, happy Friday, everybody. We made it. It's one more week. It's been a crazy week. Some of you more so than others, with nobody told us we're going to do civil unrest at the same time as we try to manage a pandemic. And for some of you guys, I know that was a challenge and continues to be a challenge. We'll talk about that a little bit as we go on here. So I just want to call your attention to really, technically, we had two AFLs, but more they were a follow-on of previous AFLs. One we know for sure is the testing. This is the third part in the series, and this AFL really prescribes what the expectation is for testing within our facilities. Most of it we've covered on these webinars before, and you guys are familiar with. The most important thing, if you did not read the fine print there, is the expectation from the Department of Public Health is that on June 30th, everybody will have completed their baseline testing. And so we know for you guys that are working with your counties, where the county is doing the baseline testing, make sure that they're aware of that kind of self-imposed deadline from CDPH. I think most of them are, and the ones that I've talked to are working to meet that deadline. But just, I'm not able to talk to every health department, so I don't know what their capacity is to meet that. But I think most of them are in line with that. But if you have a county that is either not going to participate in helping you do the baseline testing, I need to know that, or we need to know that. And then also, if they are going to do the baseline testing, if they don't know if they'll get it before June 30th, let us know so that we can reach out to the Department of Public Health, CDPH, and ask them or get some accommodation based on whatever your county's workflow is. And then this is not a repeat of last week. We talked about that heat advisory, and while it's much cooler today, and along with that heat advisory, we talk about the loss of HVAC and some of those other things. The WHO, the World Health Organization, and the Pan American Health Organization put together a really nice PDF that talks about HVAC in a COVID environment. So, print that PDF off. That's linked right there. It's also on our website as well. And give it to your physical plant staff as we move into the warmer summer months. That'll be a good tool for them to use, especially if you have COVID in your building. If you don't have any COVID in your building, obviously this wouldn't really apply. So. All right, so we've got some initial feedback on mitigation plans. I haven't talked to anybody that said they were accepted, just sent in, and they said, yep, you're good to go. There's been a feedback process within this that people are getting from the district offices. And one of the things we're hearing is that the district office just wants you to submit the checklist only. And I'll just say that checklist is not a plan. It's kind of metrics that the state wants you to meet with your mitigation plan, or at least that's the way it seems to me. It's just check boxes with no actual tasks or procedures to meet those those kind of goals or metrics. So as you get feedback from that, if you're hearing that consistently, I just want you to know it's your plan. I would explain that to the surveyor and say, that's great, I'm signing and sending the checklist, but my mitigation plan is the procedures that are meant to meet that checklist. And that's kind of how we set up the template. So if you're using our template, and when I say that's just a baseline, you guys add a lot to that. And I've heard from folks that they've submitted mitigation plans anywhere from 30 to 80 pages and or even more. And I know that the district offices look at that and they go, man, I have to review all of this. I realize that it makes it easier for them to review the checklist, but really the checklist doesn't give you any procedures on how to meet those kind of things that they identified. So there is so they released 2 checklists. This checklist that you see linked here is the second version of the checklist. The first checklist had that language that required attestation, and it had some other things. The second checklist had removed that, I believe. So I reviewed it yesterday. I didn't see that language on it, but if that language still exists, let me know and we can bring it up with them. And we need the feedback from you guys as to what they're what they're expressing difficulties in understanding. And if your clinical judgment differs from what they're saying, this is your plan, guys. You have to make it work for you. And each one of your facilities is highly different. There is no one size fits all solution. And you know, I'll talk in a little bit about the HAI call yesterday where they talked about 4 cohort categories and things like that. A lot of this is we're trying to model other things that have worked in other states to minimize the spread within a building if you have an outbreak. The reality is the physical plant for some of our buildings makes it virtually impossible to do that. And then the staffing model to do 3 or 4 cohorts is really, really difficult. So if you get folks asking for that, like where's your 4th category, things like that, you have to express to them, look, this is the only way it works in this particular building. And that's why I wrote it the way I wrote it. Like I said, you're going to be held to this standard. So whatever you sign and submit, that's going to be what you're expected to do. And if you can't accomplish it, don't put it in your plan. It's just as simple as that. We've expressed a bunch of concern about the mitigation plan and what's achievable for folks. And if it's not achievable for you, it just seems silly that you would put it in there. Now, there may be some things that are, if you get feedback, you may be able to learn like, oh, maybe I could do it this way and I could do it that way. I've actually heard from a number of people that the feedback they're getting during the mitigation review is helpful. Doesn't mean it's always helpful, but try to take it as an objective thing and look at what they're saying and say, does this make sense? Can I achieve it? If I can, then okay, I'll add that to my plan. Or if I can't, these are the reasons why I can't, and this is what I'm going to explain to them. So I think you guys are experienced at that. You do it when you do your plan reviews every year when you go through surveys. So that same kind of thing where you have to enlighten them as to why you wrote it the way you wrote it. So, and then the lab resources, the good news, really good news that I've heard from some CEOs all the way down to folks working in buildings is that they've contracted with some of these quote unquote full service lab companies, and these full service lab companies are integrating the billing for staff into their testing plan. So that really takes a big weight off your shoulders as an operator, like how am I going to get these folks paid for? And these full service companies come out and do the entire thing for you. They're doing the tests, they're collecting the samples, they're refrigerating them, they're sending them to the labs, they're giving you an interface to access those results and things like that. If you're looking for a list, this gets updated actually pretty frequently. This the link that I've got listed there was updated yesterday. They added a couple more companies on there. I know there's even more companies that are listed on there that I'm hearing from individual providers they're using that are not even on this list. So I know there are even more companies out there doing that. And I will say, if you're in a county and your county, I'm talking specifically San Mateo, and this may happen in other counties where the county is doing the testing, which is great. We love having a kind of a full service or an integrated approach to doing the testing. The problem is they're not sharing the results with the facilities, and that kind of flies in the face of how we're going to manage an outbreak if we don't know when people turn positive. So if you're in a county that is going to do that testing for you, make sure that you understand what that interface looks like to be able to get those test results, because you're going to have to be able to provide that to CDPH, especially if you have positive cases. But if you have questions about the lab resources or anything like that, or you want to, if you looked at that list and you've tried everybody and you want names of more people, by all means, just send me an email, and I have a few more of the quote unquote full service companies that have not been fully vetted, but I know other folks are working with them. All right, so let's move on to the reporting for just a little bit here. I realize the reporting has just been really difficult to catch up with. I don't want to give CDPH a hard time for not being able to do this 100% perfect right out of the gates. This is something that they've never done before for long-term care in terms of this statewide data collection on a daily basis. And then to kind of step on the grenade and say, hey, we will also help you by, if you confer your rights, we'll also do the CDC reporting that the feds are requiring. I realize that has caused some issues. I super appreciate their ability to, or their understanding that all this reporting takes away directly from patient care. Now, we haven't figured it out, and there's lots of issues still going on with that, but I just want to throw them a bone a little bit. Like, they didn't have to do that, and we appreciate them taking our advice and saying, look, we're already overburdened, we don't have time, can you figure out a way that you could do this for us? Now, there's some growing pains with that. There's still 80 facilities that are not signed up, at least from a list that they gave us, and another approximately 200 have not conferred their rights yet. Now, who knows if that list is accurate? We've taken that list and we've contacted some companies independently to ask them, hey, your name's on this list, have you done it? And a lot of them have said, look, we went through the process and we signed up, or we haven't got our SAMS number yet, and we can't go past this point. We know there's still problems. Please reach out to us and let us know so that we can help you get through that process. The fines for not reporting are going to start pretty soon. I think if you have print off those emails where you send them in, print off the emails where you're asking for help and you're not getting any response, document any calls that you're making to try to overcome this. Things like that, those kind of data points, so that we can show, or you could show afterwards, if they say, hey, listen, we're going to cite you for this, you could say, nah, that's not going to work, because on May 14th, I sent this email, May 17th, I sent this email, May 25th, I sent this email, that kind of thing. That's going to be needed in order to prove that you've gone through the process. And then checking for accuracy. We've talked to some providers who have gone in and checked their information afterwards to make sure that what is being reported on the NHSN website is accurate. And for some folks, it has not been. Now, there could be some operator error, so we want to make sure that we're inputting the information in correctly, but there could be error since this information is being transferred from your daily polls into a a weekly thing for CDC, there could be some inaccuracy or some errors at that point where CDPH is entering the data for you. So if you have those accuracy problems, let us know. And then there's like a PDF FAQ, and it kind of gives you an idea of who to contact and when to contact them if you're receiving issue or having issues on the accuracy of the data. And if you go onto the NHSN website, there is like a calendar day that you can click, and then you can re-input your information into that calendar day. I'm not sure if you've conferred your rights, whether you can go back in and do that. I'll have to double check with Patty, but I do know that there's a way that you can go into the NHSN website and you can click on the calendar day and replace the incorrect data with the correct data. So if you have access to that website, I suggest at least go look and make sure it's correct. And then why is it that we harp on data? I know it's incredibly burdensome, and it's not something that we're normally accustomed to. I think as we get used to the process, it'll take us less and less time to do it, and we iron out these technical details. But data is important because it will allow us to track, kind of where this virus is heading and how it's impacting people in certain areas of the state, and maybe able to tell us stories about how it affects certain buildings of size versus buildings of a smaller size, or a lot of different things. The reason why I say that is because there was a really large series of changes in clinical guidance. And unless we have good data to be able to study the impacts of those changes, we won't be able to know if those changes actually materialized into benefits. And so that's why it's really important. I'll give you an example. So, April 15th, the CDPH issued the advisory that all healthcare professionals or all healthcare workers in a skilled nursing facility should wear source control. That's a pretty big switch from what it was prior to that. And the thought is that after we've changed that, especially given the amount of asymptomatic transmission that was going on, that we should see a downward trend versus not only new cases, but the amount of new cases within a facility when an outbreak is determined. So the only way we can do that is by having good numbers. And it just so happens that at that period of time when we should be seeing those drops in the numbers, that's when the data issues at CDPH really took a nosedive, where we went from 90% or 85% of the buildings reporting down to 50%. And that was due to a technical error. But we extrapolated the data based on the number of responses we got. And it did tell the story that we thought it was going to tell. It told the story that not only were cases decreasing in nursing homes, but the outbreaks in terms of their size were also decreasing. So that's why it's important for us to tell that, get that data, because we can tell that story and we can go, look, we know this works. Let's keep doing it. Let's keep our feet to the fire and really buckle down. And then if it didn't work, we would say, hey, listen, gosh, this is not working at all, or it's not slowing it at all. This thing is airborne in a way that we can't protect ourselves. And so we could tell a story from the data just by having good numbers. That's why it's really, really important. And just as a last thing on the data, a reminder, when you go to report your data, you're not reporting a cumulative total. You're only reporting new cases that happened since your last report. So if you reported yesterday, it's only the new cases that you're reporting today. And so I think some folks may have entered cumulative totals into these data sets. So we may not have 100% accurate information, but just as this will also not make it look as bad, because if you're entering 12 or 4 or 2 every day into this thing, it could artificially inflate the numbers. So want to make sure that we're only reporting new cases from our last report. And Deanne will correct me if I'm wrong once we have Deanne join us here. So, and then I listened to I participated in a webinar for Locked-In, which is a risk management company here in California, and they're very actively involved in CAF. But they had a couple of Cal OSHA attorneys or employment attorneys, shall we say, did more than just Cal OSHA stuff, but fascinating, really eye-opening kind of webinar as to what the exposure is for us as administrators, and for those of us that have staff that are working in possibly in COVID positive buildings. So one of the big takeaways, obviously we know Cal OSHA has a really active enforcement arm, even more active and than CDPH. And you go, how is that possible? I'm not aware of, like CDPH, when we get a deficiency or we get a finding, there's a process that we go through to kind of document how we got to where we got, and it's almost as a reasonable process in comparison to the Cal OSHA process. So one, I realize not everybody's a workplace safety guru, so the Cal OSHA is really difficult stuff to follow and kind of become a subject matter expert on. If you're an administrator, it is definitely not something you really is in your wheelhouse all the time. So it's understandable that you would not be 100% familiar with this, but I want you guys to understand that there are two kind of things. There's a recording of when a staff member becomes positive, especially as we ramp up testing for staff. We know we're going to catch some asymptomatic staff and stuff like that. And then there's reporting of COVID positive staff. So in terms of recording COVID positive staff, we're talking about writing it out on that the OSHA 300 form. It's a one-page form. That should be, you should be familiar with that. That's where you document a workplace injury. So how is this, does this, would somebody testing positive for COVID and not having any symptoms at all, would they be recorded there? And I go, well, it really depends on how they got COVID. Are they the only person in your building with COVID? If they're the only staff member and you have no residents that tested positive for COVID, the likelihood that they got it at your building is very, very small. More than likely, they got it somewhere in the community. And for that instance, I would say no, that you don't have to record that. Now, I'm not an attorney, but it doesn't seem to me that's a workplace injury. If you have COVID positive staff that test positive and you have multiple staff that test positive or residents that test positive, then I think it's likely that it's possible. Well, I don't think it's likely. I think it's possible that they could have got their COVID within your building. And if that's the case, you would want to record that on the 300 form. And there's little check boxes that make it really easy, especially if you're going to hold them out from work. There's a section that asks to hold them out for work. You have to document that and record it on the 300 form. So now, how does that differ from reporting? Reporting COVID positive staff, when you do that, is when they've had a serious injury or death. Now, serious injury has a specific definition in Title 8, and you can find that definition on the website, on Cal OSHA's website or the DIR website. The reality is, if they're hospitalized for COVID, for anything other than observation, then you would have to report that. Obviously, if the person passes away, that you're going to have to report that as well. And so how do you do that reporting? Because this requires you to take immediate action to Cal OSHA. So Cal OSHA says in an instance where somebody goes through this process, serious injury or death, you have 8 hours to report that on that linked form. So you see that form right there that says report accident or injury. That's a form. You click on that, you download it. It has the information as to what has to go into the report, and then you can email that report or you can call the Cal OSHA district office. You got 8 hours to report it. In extreme circumstances, they can go up to 24 hours to report it, but really they expect it to be reported within 8 hours. And I think it goes on to say exigent circumstances. I don't know what they consider exigent circumstances, but just know that, you know, within a workday, 8 hours, you've got to report this to Cal OSHA. And then one of the last things they mentioned was on the fit testing. And so I know we've had some talks about this, and I've recommended that you guys that don't have all your staff fit tested to get like fit test kits so that you can do the fit testing yourself. The fit testing kits are back ordered from virtually every supplier, and it makes it really, really hard to get. I just want you to be aware, you don't want, Cal OSHA's enforcement says these folks cannot work with COVID positive people unless they've been fit tested for their N95. So don't have those folks work a COVID positive unit if they've not been fit tested on their N95s. Unless, well, they can wear an N95 for source control, according to the webinar I listened yesterday. And I think that's fairly accurate because it's a level of protection that's higher than a traditional face mask. They did go into more talk about the type of face masks, and there's been a lot of talk about what are we talking about? We're talking about surgical masks for your healthcare workers, not cloth masks. Those you can give to your residents and things like that for source control, but they should not be worn by healthcare workers. And then if you cannot find a fit test kit to do it yourself, there are companies and that do mobile fit testing. I know that some counties, their public health departments, we've told them that not everybody's fit tested. Can you help us get the folks fit tested? Can you get, can the fire department come help? Can you send a public health nurse to help? Or maybe you have hospital partners that would be willing to help people you get referrals from. It's really important that you get this done, guys, because these folks do not mess around. The Cal OSHA enforcement branch is really strong. The fines are incredibly high, not to mention that a non-fit tested mask doesn't really protect your healthcare workers. And so we realize the risk to them is small, but there's still a risk. And we don't want to put them at risk if we don't have to. So we want to give them all the protection we possibly can. That means a fit tested N95. For those folks that want to hire a company to do fit testing, you got to start that process now, because most of these companies that are doing these mobile fit testing, they're doing them for dentist offices. They're like every industry that you can think of that's going back to work that needs an N95, they're doing it now. So you've got to get in the line to make sure you can get scheduled for the end of June or July or whenever the soonest is. And those fit testing, I've not talked to a bunch of mobile companies, but they all range about $100 to $150 per person to do the fit testing. So if you got 100 staff, that's, you know, $10,000 to $15,000 to do the whole building. So if you can find a fit test kit or find a partner that can come help you do it without a $10,000 bill, that $10,000 cost, that's probably going to help you out in the long run. And it might be you might be able to get it done a lot quicker than going through that thing. We've expressed our concern multiple times with the director of DIR who oversees Cal OSHA. We've let them know that we've got potentially tens of thousands of healthcare workers that still have not been fit tested. and we need a massive amount of help getting this done. As of yet, they've not really offered any kind of assistance where they're going to come out and help us. But my hope is that they could at least identify partners that maybe we could leverage and help that. So, but this is super important, guys, because I don't want to see you guys, talk to you guys in a year from now with hundreds of thousands of dollars in Cal OSHA funds. All right. So I feel terrible because I didn't even introduce my star co-speaker today. Essentially my boss at CAF. Many of you guys know Jocelyn Montgomery. Jocelyn started our disaster preparedness program. Deanne came along and didn't miss a beat. And Deanne Walters, who is our Director of Clinical Affairs, has been working with a collective of folks. I'll let her explain that, but Deanne's the Director of Clinical Affairs at CAF, if you had not known that, and she oversees the disaster preparedness program within some of the multiple other things that she does. So I want to say thank you, Deanne, for coming on, spend some time on your Friday with us, and talk about how we're going to resume visitation. And that, oh, I apologize. That AFL that I have linked there, guys, that's the second AFL that came out last week, and that's a reissue of a AFL. So this is 20-22.2, and it just extends the waiver on restricting visitation until June 30th. We want to talk to you guys about not June 30th as a date, but how do we do this before June 30th, after June 30th, what does it look like? So Deanne, maybe you can give us some background about why we started thinking about doing this.
Absolutely, Jason. Thank you so much for having me on today. I really appreciate that, and also all the kind words. So we are looking at, the possibility of resuming visitation, and some of you may be going, oh my gosh, one more thing, and then others may be going, oh thank goodness, it's about time that we bring our families and visitors back because we've missed them, and we're going to have everybody in between. So this really came up on the CAF side, and part of it is because we have seen and read so many different news articles, and I'm sure that you're all really tired of reading them as well about, the horrible skilled nursing facilities that are just not doing the right thing when we are running around and doing everything we possibly can, not only to make sure that the residents' clinical needs are met, but their psychosocial needs are met. And so, one, thank you for all that you are doing, and make sure all the team and effort that they're putting in are appreciated for it as well. Because things that were taken up by family members have been taken up by staff who already have been pushed to the limits in trying to stop COVID from getting into the facility or spreading within the facility. And so it's just another layer of responsibility, which I'm sure you are all up for and love doing, but it just does add to the stress of the times. So within all of the communication that we've been reading from the adversaries out in the community is that we are not allowing families to visit, and who's going to oversee us if they're not there? Well, they missed the point that we've been told we can't have visitation. We can't have anyone but essential people coming into our facilities. And of course, they kindly leave that off to make it seem like we're doing this on purpose to hide something. Well, we know that is not true. In fact, I think in many situations, a lot of our staff are missing just as much as the residents, those family members that were there every day. They came in with a nice smile, sometimes even cookies for the break room. I mean, we have such wonderful families. We also have families that are definitely very involved, and it may not be horrible not to see them every single day, but I think in the long run, we kind of miss even those interactions because all of our families we know are important to our residents. So because of that negative perception through the media that this is something we're doing, one of the questions that was brought up at CAF was, what can we do in order to try and make visitation safe so that we can be seen as being proactive and getting our families back into our communities in some fashion? Because we know that COVID, even though the rest of the world seems to be returning to a fairly normal state, we know that our residents, being such high risk for this virus, will not be returning to a normal state for quite some time. So what can we do? So at that advice, I took up the helm and brought together a group of people. So we're calling ourselves the Visitor Homecoming Collective. So the who and the why. Kind of told you a little bit about the why. One, we know how much it means to our residents to have people, and though they love us, I know they do, we aren't their family. We are their caregivers, and so they need interaction beyond the person who's providing them care. So we know it's really important to them, you know, psychosocially, emotionally, all of those things, and we want to make sure those needs are met. Now, the who. So we, of course, have some of our CAF team on there, and definitely Jason is a big voice for us in that, just because, you know, he keeps us sane when we want to run forward and just randomly do things that are unsafe. He brings us back in line to remember we have to do this safely. And we also have some administrators that are giving us their feedback on what their experience has been with COVID in their building and in the communities. We have people that are representing family who have had a family in long-term care facilities, so they could talk about like what their needs and desires are. And we were lucky enough through our CAF volunteer engagement grant to have our grant director, as well as our person who does consulting for that grant, who is a clinical psychologist focusing on the geriatric population. So we have a great group of people talking about the need for having some type of guidance for it, and you know, voices from all sides in order to make this happen. So looking now at the tiered approach, and this actually was brought up by Jason, and the things that we need to ensure that we're touching on in this guidance. And so we're going to look at it in different areas. So operationally, what does that look like? How do we make this happen at a facility? What physical plant space we need to have available, and what does that look like for this to happen safely? And then what does the personal protective equipment look like for this situation? And we're not saying for everybody to run out right now and start following these guidelines, but one of the things we would like for you to do is consider it as part of your mitigation plan. So looking over this homecoming guideline, we're going to put it up on the website. It'll probably be next week. We just want to make sure a few more people set eyes on it to make sure that we're covering most of our bases. But we're going to have it up, and you can take a look at it to implement as part of your mitigation plan for bringing families back in contact with their loved ones. Now, I'm sure you've also seen there's information from AHCA nationally that is talking about how to make this happen. So I think that we were thinking along the same lines as them as we were rolling through this. And I know that facilities across California have done very creative ways of having residents see their families. Of course, we've seen the window visits. We've seen the parades, which are just so inspirational and fun. We've also seen parking lot visits where residents are in the parking lot, and on the other side of the shrubbery, down on the sidewalk, are the family members, so that they can see each other, not through a window, and have the opportunity to feel like it's a regular visit in some way or another. So these guidelines aren't that far different from those. So we're, of course, going to say if you have any COVID positive in your building, or you have a suspect case, at that point in time, you're probably not going to be able to have visitors. You will maintain that restriction, the restricted status of your visitation. It doesn't mean, though, that once those are clear past not the testing, but the actual symptomatic, that you can't go back to a visitation policy. Then we step into what we're considering the soft visitation. And so at this point in time, it is, you know, a short visit. And some of the things that we're talking about are, you know, communicating out to the family. Number one, communication throughout this whole process is going to be huge. It's going to be part of why or why not you might receive, you know, litigation around this. We have to be more transparent in our communication all the way around, to families, to residents, to our staff, and that will definitely help us. So we want to communicate out. One of the things we're talking about is having a designated staff, and of course, if you are challenged for staffing right now in regard to patient care, then you cannot move into the soft visitation, because based on our thoughts around this and the feedback we've gotten from administrators, this would probably take someone, a full-time staff member, in order to organize and monitor this process. So if you have staff challenges, again, I would wait, or potentially look at maybe a really great volunteer that you had before that might be able to step into this visitation role. And so this person would manage appointments, because we would suggest doing it by appointment, and then also supervise the visits of the families. And we're talking the physical space would be outside with a canopy overhead for comfort, designated space, keeping people appropriately 6 to 10 feet apart. And this person would watch that. A table was suggested because we were talking about that as people come together, we tend to creep closer to each other. So a table might be a good barrier to make sure that that doesn't happen. But at the soft visit, we're talking about having just 2 people coming and doing this outside space visit. And these appointments being like 20 minutes. And then that way you have a 10-minute in between visits in order to disinfect any of the solid surfaces that are outside, such as the table or chairs that you're going to provide. Obviously, we're still going to be doing the questionnaires. We're talking just like they're doing it at physician offices, having something that they answer to when they're first making their appointment, and then again sign their name to in regards to their symptoms and those such things as they are at the facility. Physically having a specific space, parking space for people to park in this, so they can, with one of those numbers like you see at the fast food stores, that you can call and say, hey, I'm here, and that way you can let them know if the space has been cleared and ready, and if their loved one is ready to come visit them. So a lot of interesting things that we're talking about in order to ensure that we're doing this right. Visitor staff obviously have to confirm that they're going to be following the rules, and that if for any reason our staff feel that is doing that monitoring that people are not following those rules, that they can end the visit. And then of course, we will then need to make sure that once a visit is wrapped up, that the family leave the property, and hopefully there's a space. Our suggestion is not having them go through the facility at all. And so if a facility doesn't have the space outside to do that, then other considerations might have to be taken into account. Again, going to the soft visitation level would only be applicable if you have enough personal protective equipment, because if the family don't have them, then we would need to provide them, and plus the resident and staff members would need to make sure that they have them even though they're outside. So a lot of things are going into this, but we want to have all of you consider this. So it'll be going up next week. We'll probably drop that out on the forum, that it is there for you to take a look over. And the collective is going to continue to meet, and we're going to talk about what happens like in extreme weather. So we just had the weather advisory from CDPH, and as we potentially have visitation limitations going into the fall, if the weather starts changing and we have rain and other issues, then how do we do this safely inside? So we will continue to work on that, to look at guidelines to help move this visitation inside. So again, only stepping forward where it's safe and appropriate to do so, but definitely something we want to communicate and try and make part of our mitigation plan, so that way we can bring our families and other friends back to our residents. So I think I probably went longer than my time allotted, Jason, but I kind of got wrapped up in the possibility of this, and I will hang around after if there are any specific questions that pop up. Thank you for your time.
Yeah, thanks. I appreciate that. Please hang out. There may be some questions after. Thank you very much. I appreciate that.
Absolutely.
We're all super excited to see those smiles back on our residents' faces again. That's for sure. All right. So I don't know why I capitalized W there. The coming weeks. It's not like it's super important. I don't know why I capitalized it there, but in the coming weeks, these are kind of the things we'll see. And also, this week, we do know that Fema drop shipments, meaning packages of PPE will be dropped at every building or every skilled nursing facility in the state. It's not going to have from Fema or from your friends at the CDPH. It's not going to have any of that on the outside of the box. It's just going to come unlabeled. It's going to, or you won't be able to tell what it is. You'll open up the box. It'll say to the facility administrator. I don't believe they're sending them by name to the administrators. And then inside the box, what we've heard that you can expect to get is some face protection or eye protection, gloves. Some people have said they've got surgical masks, and other people have said they've got cloth masks, but it'll be one of those two things. We've not heard of any N95s being sent in these drop shipments, and then isolation gowns, which are actually probably the hardest thing to get right now. So those, if you've not got them, you should be getting them very shortly. I know I'm getting emails from folks all over the state saying they've received them. I do know that FEMA or somebody has told the counties that the counties need to call you to confirm that you received this information. And many of you in Los Angeles saw we sent out a survey to ask if you had received the information. I think what might be easier is if you guys listening to this call, if you have not received your FEMA drop shipments, let me know so that I can contact the counties and let them know. I'm hearing from enough people that I'm assuming most of you guys are getting these, but it may be easier for us to figure out the folks that have not got them rather than the ones that have got them. I mentioned this earlier about the HAI call yesterday. Was a healthcare associated infections call with CDPH, and they talked about 4 cohort groups. And when we originally looked at their recommendation for the mitigation plan, that was a model I looked at in other states. The reality is that probably works really well if you've got a facility that's 200 beds or more. But in terms of staffing 4 distinct cohort groups, it's going to make it really, really hard to do. So I sent an email over to the folks at the team over there and asked them what was the change from 3 to 4. If 4 cannot be accomplished, is 3 okay? Because that's what we were planning on doing. So once we have an answer for that, hopefully they'll address it on the HAI call next Thursday. But if not, I will address their answer on the webinar next week. Liability is still pending, and while I once held out hope, I'm unsure. I'll say that the governor appears unlikely to, or at least hesitant to sign any more executive orders. The legislature seems to think that they want to be involved in the process, and so it may require, the governor to propose something to the legislature, and then us to kind of really push the legislature to get this done. To that end, CAF is going to testify in front of the legislature next week on Tuesday. Our CEO is going to talk, and that will be one of the main topics is pending liability and getting that done. And then I know I talked about civil unrest. God, we didn't even think about that when we're operating our buildings during a pandemic. But this has happened to a couple of facilities where they were directly impacted, probably had issues with their staff getting to work and things like that. And not just skilled nursing facilities, but other healthcare entities also felt some impact from that. But that kind of puts that thought in our brain like, yeah, we're in a pandemic, but that doesn't stop other things from happening. And other things for us in this state are pretty cyclical. We know PSPS now is a thing we're going to have to deal with. That's going to come up pretty quickly here. Wildfire season for those of you in communities that are impacted, and that's most of us in California. So we're going to adjust the policies and procedures that we've developed for evacuation and shelter in place with COVID positive in mind. If you're using our template for your emergency operations plan, I'll send out a note on the forum to let you know that we've adjusted that, and with a link to the policies and procedures as we rewrite them for doing it with COVID. I want to confer with the folks from EMS and the folks that would actually be coming to assist you with evacuation if that happens. We'll develop something that's kind of a thought out approach that protects everybody. because we don't want to get other folks or expose other folks to COVID if we don't have to. So just think about that. That's some planning that you guys can start thinking about as we move into the wildfire season. It's definitely something of concern. So with that, I want to thank you guys and jump right to the questions. Courtney, do we have anything? We've got about 10 minutes left for questions.
Yeah, we have a few questions. Can you hear me okay?
Either your phone's got to go down or your computer's got to go down. One of the two.
How about now? Is there still an echo?
Yeah, still feedback.
Okay. Jamie, if you can hear me, would you mind taking a question? I have to call in.
Hey, Jamie, are you there? Well, I guess there's no questions. No, I'm just killing
there
time.
are questions. I'm sorry, I don't know what happened, but there are some questions. Let me read some off to you.
Okay.
Let me see. Let me just scroll down one moment. It says, so this is from Julie. It says, we had an issue that CDPH did not have record of one day we reported and claim they cannot do anything about it. So the day is missing on the NHSN calendar. If we can enter it ourselves, would it be okay to enter the data multiple days later after we discovered it?
You know, it's funny, as I look at that FAQ from the CDC, it says you can go all the way back to May 1st. But I don't know how long they've been putting in the data from you, but it would seem to me that they're saying you can go in and correct it at any point if it's inaccurate. Next question.
Apologize, I was muted. Our facility is required to confer rights to CDPH. I would rather provide data to NHSN directly.
You sure can. Yeah, you don't have to confer your rights. It would just it would save you a little bit of time. Yeah, the NHSN reporting is only done once a week. So I've not gone through the process, so I can't tell you how laborious it is. I just know that the process to get it set up is labor intensive. Let's put it that way. But once you got the process set up, if you're okay with doing it, for sure. But if you need that extra time and you want to rely on CDPH to do it as well, you can. If CDPH does it and they make errors, it's not really your fault. So I'll just say that. All right, next question.
Great.
Hey, Jamie, this is Courtney.
Oh, perfect.
I got the phone call working. Okay, great. Thank you. Sorry about that, everyone. Okay, so our next question, can you explain again what is supposed to be submitted in our mitigation plan? Is it just the attestation?
No, it's a checklist. So if you go onto that AFL, the first link, let me double check, make it's the first link. I believe it's the first link on the bottom of that AFL. And then that link has a checklist. It's a fillable PDF. You put your name in this, it says you're the administrator. I think it's the first link. I'm just double checking right now. So, but at the bottom, it's just a checklist. It doesn't have any procedures listed at all. Oh, I'm sorry. It's the, let me see. Is it the first? It's 2052 and it's the first link, I believe. Yes, it's a PDF, a fillable PDF template. And that's the first link on, if you scroll to the bottom of that AFL 20-52, and you put your name in, the facility name and address, and you check the boxes. That's supposed to be submitted with your mitigation plan. But we've got some feedback that from district offices saying, I don't need your plan. I just need you to check this box, sign it, and send it back. That's not correct, because this is not a plan. I mean, you can send that in if you want, but this doesn't give you any idea of how you're going to accomplish these things. So And when they say attestation, they're not talking about us attesting to that. They're talking about the county has to attest that you have 14 days worth of PPE. You have to do all of this stuff. So that's the county's attestation, not our own. And that's our understanding, and that's what they told us. So, all right, next question.
Yes. For the families who will come to visit, are we asking for them to be tested too? That is aside from the screening questions and temperature monitoring.
No, I think what the goal in the well, at least what we're thinking about now, and it may get to the point where that's appropriate, but the reality is one, I think it would be a HIPAA violation. We can't ask them specifically for their medical information. But I don't see a point unless we got to a point where we could have instant testing. Would we, if they tested yesterday, there's still exposure. If they tested 10 days ago, there's obviously more exposure. If they tested a month ago, that doesn't tell us anything. So when the test is done, yeah, maybe if it's an instant test or one of those ID Now tests where you can get the results, maybe you could do that. But I think what we're thinking about doing is we're maintaining all of the distance. Our goal is to maintain all of the social distancing and all of that within that kind of visitor guidance, so that we're not exposing them and we don't have to worry about them being positive or negative. I think that's kind of the way we're leaning towards, since the testing doesn't offer us a really indicative window of whether they're negative or not, unless the test is very recent. So,
all right. And this is Dee, and I'll just jump in there too, Jason. And in our guidelines, it's really, you're going to be doing the same kind of questions and such that you're doing with your staff. You can take their temperature, but really it's going to come down to what you are going to be able to do at your sites and what you put into your plan. So we're just providing some guidelines, but they would be masked. So, and the distancing maintained, just in an area where they're closer to their loved one. And so without knowing for sure, like Jason said, we're just saying you're going to go through all of those, but to require a test, might be a burden, because trying to do that on site, and those aren't available to us right now. So, but however you decide to organize this, that makes sense. And obviously CDPH is reviewing our plans, possibly. And so, you would need their support. And of course, I should have said this too, depending on what your county is allowing. If your county has much more strict guidance than what CDPH is having, then you would probably want to ensure that they would be supportive of these guidelines as part of your mitigation plan, so that you're not stepping on their toes as they're trying to maintain the community safety.
All right, we got time for a couple more questions, Courtney.
Okay. Someone said a vendor has approached us regarding the availability of an in-house testing analyzer. Which is approved by the FDA for emergency use. However, CDPH specifies that a commercial lab must be used. Is that true for other locations?
Yeah, the reason being is they have a very specific type of test that they want done, and that's a PCR test, and can only be read in a CLIA approved lab. So they're not like growing on the shelf. I still think there's a question about the accuracy of the systems that provide more instant results. And until they can get to the point where it's more accurate, they're not going to use it in a healthcare setting. They may use it in other industries, but for us, because the risk is so great, that they really want to confine it to just that specific type of testing. All right, next question.
Yeah, sorry, we're getting a lot entered and it keeps moving. Let me find where we were. Can we use non-medical masks in clinical settings? We picked up our PPE supplies from LA County today, but the masks are all labeled non-medical.
Yeah, without looking at the mask, I don't know. What we want is surgical masks are considered, we're going to use those for our healthcare workers. If they're not a surgical mask, meaning that those 3-ply masks, then that's not used from our healthcare workers. Those are cloth masks, and they're fine to pass out, give to your staff. when they go home, they can use them. You can give them to your residents. You can give them, to other folks, but it's not used by healthcare workers. So I appreciate the gesture, but if they're not those 3-ply masks, we don't want to use them for healthcare workers. Next question.
Initially, we were told that non-direct care staff, office staff, and kitchen staff can wear cloth masks. Is this still the case?
No, that's a simple one. It's when I read the guidance from the healthcare workers, it essentially is everybody in your building, because they make the definition so narrow to get out of that. What qualifies as not a healthcare worker, it's essentially everybody in the building, from maintenance to dietary to laundry, housekeeping, all of them. Yeah. Next question.
If hospitals choose to test prior to discharge, are we looking to reduce the number of days new admissions would remain quarantined?
Yeah, I mean, this is a big thing, and we continue to ask, like, hey, listen, the guidance is to test all our residents. Why are we testing them after they come from the hospital when the hospital has access to tests and they could do it right there? It makes no sense at all. We know that not every hospital is doing this, but the hospitals that are doing this, they're doing a good job of testing it. Now, what we can do is we can take the date from they took the test, and we can start our calendar day count from that date. So if they were tested 3 days prior to discharge, we can count that towards the 14 days. But I don't think it's likely they're going to remove that 14-day kind of quarantine requirement. It just does not seem likely that they do it, especially given the amount of asymptomatic transmission and the amount of transmission that happened in that 10 to 14-day window in other parts of the country. So they're probably not going to change that at all. All right, I want to be cognizant of folks' times. We're a couple minutes over. Thank you guys so much for joining us today. Have a wonderful weekend. If you have questions, please reach out, info@caf.org. If you want to review this webinar or any of the previous webinars, you can do that at the youtube.com/CAF-TV, and you can see all of the webinars recorded there. I want to say thank you to Deanne and Courtney and Jamie again for helping us out today, and you guys have a great weekend. Thanks.